Thank you for joining iMeet.
Okay, welcome to the AABIP webinar series. My name is David Shaw, and on behalf of myself as well as my co-moderator, Russ Miller, I would like to thank you for joining us for today's session. Before we start, I would like to inform the audience of several disclaimers. Number one, please note that this webinar will be recorded and available for future listening and viewing on the AABIP website. Secondly, the AABIP does not specifically endorse any technologies or products. And lastly, that the contents of this presentation represent the opinions and expert opinions of our speaker. During the course of the talk, since the audience will be muted, we are encouraging audience participation online through the iMeet platform. There is a chat box that is available for you to answer questions that our experts may be requesting input from the audience, or if you have additional questions that you have, you can type them in there. At the discretion of Dr. Shepard, he may choose to answer those questions during the course of his talk or defer them until later. And we will aim to have a question and answer session as well towards the tail end of this discussion. So without any further ado, I would like to thank Dr. Wes Shepard for joining us today. He is the Director of Interventional Pulmonology at the Virginia Commonwealth University Health System in Richmond, Virginia, and he will be discussing today some interesting cases and situations involving metallic airway stents for malignant central airway obstruction. So without any further ado, let me turn the time over to Dr. Shepard. Thank you.
Thank you, David, very much, and it's a pleasure for me to be asked to participate in the webinar, and I thank you to our audience members who are here with us tonight. Some of you, it's later than others, but welcome. And we're going to spend the next 30 or 40 minutes or so talking about several basic aspects of metallic airway stenting for malignant obstruction, but also hopefully highlighting some key technical points and considerations as well. These are my disclosures. And we're going to describe the available stents currently available in our market, discuss to some degree the evidence in the literature supporting their use, and hopefully, through some clinical cases, examine some more subtle nuances and considerations and applications of airway stents and malignant disease. I'm going to attempt to poll the audience on a few occasions here. I realize not everyone may be able to participate, but just so I have a better understanding of the audience, if you're able to type in at all your response just to get an idea of what is your current practice in terms of what stents are you currently placing in your practice. Getting a few answers there, a lot of ease. So of those of you that answered, it seems that many of you are already fairly experienced stent operators from your options of being able to place Aero, Ultraflex, and silicone stents. So that helps me a little bit. There may be others of you on the call who are in a different category who have some experience with metallic stents only, or maybe not any experience. So it's important to remember when we talk about airway stenting in general, but particularly with malignant central airway obstruction, there are many options, and most of the time stents are not being placed in isolation. It's typically in the scenario of a multiple modality approach. It's important to remember that metal stents are one of the therapies that provide immediate results, And I can't emphasize enough that stents are foreign bodies, and we'll talk about that a little bit more as we move on. Obviously, in the setting of malignancy, the common symptoms are things you know well: shortness of breath, post-obstructive pneumonia, hypoxia, sometimes failure to wean from mechanical ventilation in patients in the ICU. Also highlight another category of asymptomatic central airway obstruction. And the reason I point this out is because I think it is a little bit different scenario. We do sometimes get asked to evaluate patients who have pretty severe central airway obstruction, but maybe they don't have much in the way of symptoms. So these patients are sometimes a little bit more of a dilemma in terms of, do I put a stent in someone whose airway is fairly narrow, but they're not symptomatic? Is this a case that might progress rapidly, or other considerations? So that group of patients is a little bit different. Other typical metallic stent scenarios, of course, malignant tracheobronchial fistula, and then some other non-malignant scenarios: airway tear, traumatic airway dehiscence, lung transplant complications. We're not going to talk about those tonight because those aren't directly malignant related. When we're talking about malignant airway obstruction, we're typically talking about placing metallic stents in the trachea, main stem bronchi, bronchus intermedius, and usually there's alternative options for patients that have lobar or segmental bronchi obstruction. However, that's evolving a little bit, and we're going to talk about that later on in the webinar. Many of you are familiar with the typical differences between expandable metallic stents and pure silicone stents, with metal stents tending to migrate less, having more flexibility in terms of insertion with both rigid and flexible bronchoscopy, but of course often more difficult removal and other risks such as erosion or perforation. They tend to be more conforming to the airway, and of course we're using them in malignant disease only, with few exceptions. And just the other key thing to point out, silicone stents offer the ability of on-site customization. In other words, you can cut them, cut holes in them, adjust them to the needs of the moment, whereas with metallic stents, you're pretty much limited to manufacturing sizes. Again, just to point out where stents in general fall in the schematic of malignant airway obstruction. If patients have extrinsic compression or both extrinsic and endobronchial lesions, then stents may be an option for either of those scenarios, but again, typically in conjunction with some other endobronchial therapy. So let's move on to our first case. I've tried to keep the history here fairly simple, but this is a 58-year-old smoker with no significant past medical history, 3 months of progressive shortness of breath, and mild hemoptysis for the last week. They're on no medications. Their oxygen saturation was 91% on room air. Vital signs fairly unremarkable, and physical exam significant mainly for decreased breath sounds on the right. This is the CT scan, and again, I've given you limited representative cuts for consideration. But the key findings here obviously are a very large right hilar and upper lobe mass, which more or less obliterates and collapses the right upper lobe. This is a scenario where we often see that it's difficult to discern where the mass begins and ends and where the actual lung begins and ends. You can see a large area of central necrosis and you see no evidence of a right upper lobe bronchus either. As we come down a little further, you can see the right main bronchus, and the bronchus intermedius is in a slit-like fashion, almost completely closed off here relative to the left main bronchus. Additional significant mass effect posterior. And then another slice further down, here in the subcarinal region, you can see some adenopathy, but at this point we can see the right lower lobe bronchus and the right middle lobe bronchus take off, which appear to be fairly patent. So when I look at a scan like this and I'm thinking in consideration of airway stenting, I think there's several key things that are going through my mind as I review this type of imaging. The first one of which is the right upper lobe is probably not re-expandable. There's no evidence of a right upper lobe bronchus probably completely compressed or filled with tumor, and it's very unlikely that it's something that we would be able to restore patency through any bronchoscopic means. So that's important to me as I decide what type of stent or what length stent I might select in this case. And it lets me know that jailing or covering over the right upper lobe bronchus is potentially an option here. The other key finding here, as I already mentioned, is that I can see the distal airways. A lot of these cases I may not be able to discern on the CT scan whether or not there are viable, healthy airways beyond the obstruction that I can place a stent and actually salvage. It also helps me know whether or not I, in some cases, need to do a flexible bronchoscopy inspection before I might receive a rigid bronchoscopy for the purposes of stent placement. Not every patient that I see in consideration for stenting has to have an airway inspection with flexible bronchoscopy first. There are CAT scans where that is absolutely necessary to discern the patency of the distal airways, and there's CAT scans where it's fairly obvious that the distal airways are patent. So all of those things are important things to think about as I look at this case. So the standard questions I ask myself when I'm thinking about airway stenting, the most important one is the airway obstruction the likely cause of dyspnea. Well, that sounds like a very obvious question, but the reality is, in this population of patients that we see with advanced malignancy, there are numerous causes of shortness of breath, as you know, in these patients. They often have pericardial disease, pleural disease, pneumonia, pulmonary embolism, advanced emphysema. So it is important to discern how much of their symptoms are truly coming from the airway obstruction. As I mentioned previously, is there expandable lung distal to the obstruction? Sometimes this is hard to discern. Is it a benign or malignant obstruction? What's the type of lesion? What's the likelihood of a significant tumor response to treatment? Is this a lymphoma or a small cell tumor or some other tumor type that might shrink rapidly with chemo or radiation? And then future surgery, that's really a question that's more relevant to stenting benign airway processes, but you never want to compromise any chance of future surgery. This is an older schematic, but it just represents the concept of jailing a lobar bronchus. Now, this particular illustration is on the left side, and this is a tumor that's encased the left upper lobe and segmental branches. And so when the stent was illustrated here, you can see the stent is beginning in the left lower lobe and, of course, covering over the left upper lobe, effectively jailing or covering an airway that was already completely closed off by a tumor with no hope of restoration. Now, this particular example happens to be on the left side. We see this much more commonly and most commonly in the right upper lobe, as in the case that we're looking at now. So our patient went on to have bronchoscopy, and as you can see here, the left main bronchus was fairly patent. The right main bronchus was nearly completely occluded by endobronchial tumor and also extrinsic compression. So the patient had both findings. We were able to pass a small flexible scope past the obstruction and visualize distal airways, the middle lobe and lower lobe and superior segments, and see that they actually look similar to what we saw on the CT scan, and that they appear fairly patent. So as I mentioned earlier, airway stenting is oftentimes not done in isolation, so usually done with some other photocoagulant or mechanical debulking modality, balloon bronchoplasty, possibly to dilate the airway ahead of time or to help expand a stent once it's in place, but with the basic principles being of maximizing the airway diameter with debulking prior to placing a stent. Obviously, depending on one's practice and experience, this may be done with rigid or flexible bronchoscopy. In our practice, for more severe central airway obstructions, we prefer to do this with rigid bronchoscopy, as in the case showing you currently. So back to the case. I've shown you the distal airways are patent. The right upper lobe is completely obliterated. The segment is both extrinsically and endobronchial occluded. So I'd like to hear from a few audience members here. What would be your stent choice at this point? And don't worry, even though I can see your names, I'm not going to call on you individually. Unless you're one of my former fellows, then I might. So we have a vote for couple votes for silicone, Aero stent, partially covered Ultraflex. All right, so it's always fascinating to see. We're getting a real mixture of responses, and obviously I recognize that in part your answer to this question probably would depend on the bronchoscopic findings in a lot more detail than what I'm presenting to you. So let me just tell you what was done in this particular case. We chose an Aero stent, and the stent extended from the carina down past the right upper lobe, jailing the right upper lobe into the distal bronchus intermedius. Here's the carina, here's the stent, here's the distal airways here. So we chose a silicone, we chose the Aero stent for a couple different reasons. Number one is, and this is a 14 millimeter diameter stent by a 30 millimeter length. And the reason we chose this particular stent was because there was a decent amount of mucosal and submucosal tumor, so we wanted to cover that as much as we could with some overlap. And a covered Ultraflex with its ends uncovered would not completely cover the tumor in this case. And also, second of all, because the actual shape of the airway was fairly uniform, meaning the diameter on the proximal end and the diameter on the distal end were fairly similar. In other words, it was a non-conical shaped airway, and Aero stents tend to sit better and open better in airways that are a little more uniform in diameter without large discrepancies in the diameter from one end of the area that's being stented to the other one. So moving along, what's the most common airway stent used worldwide today? And feel free again to type in your answers. The Aero Merit Endotech stent, the Ultraflex metallic stent, Dumine style silicone, dynamic Y stent. Right. So a number of you are, I'm getting a lot of C's, so you guys are a very international and global group. So the reality is it's very likely the Dumine style silicone stent, because of its popularity and widespread use in Europe and other countries. It's likely not the most common stent placed in the United States, but ultimately we don't really have great data on the sheer numbers of Ultraflex or Aero stents specifically that are being placed in the U.S. And the number is probably evolving. As you know, the Ultraflex covered stent was off the market 2 to 3 years ago, and that Aero stent was the most popular stent, and now Ultraflex has been back on the market in the last couple of years. So it's probably a moving target as well. Just a couple of comments on the Aero stent itself. Many refer to this as a hybrid stent. I think that's an arguable topic. It is a nitinol stent that's fully covered. It's cut from a single piece of nitinol as opposed to woven wire. It's still technically the newest stent on the U.S. market. It's fully covered. It has a hydrophilic lumen. Some of the nitinol wires are angled away from the stent, which represent anti-migration struts, and it can be delivered over a guide wire. There's also an over-the-scope delivery system as well. All right, let's move on to another case. This is a 49-year-old man with dyspnea, chest pain, and a very large mediastinal mass. CT scan of the chest showed extensive tracheal and esophageal compression from the tumor. He had multiple biopsies that were done that showed only poorly differentiated carcinoma, and despite large tissue sampling, unfortunately, this was just simply a poorly differentiated tumor that couldn't be further defined. He had intermittent stridor, which was significant, and difficulty expectorating his secretions. He underwent PEG tube placement as well for dysphagia and difficulty swallowing. Here's some representative images. So you can see, starting very high, there's a large soft tissue mass here that's encasing the trachea. The esophagus is somewhat obliterated. The tracheal lumen is quite tiny. Here's another cut further down. You can see this is at the level of the aortic arch. There's still significant lymphadenopathy that extends further down into the chest as well. Here's one endoscopic view in the trachea where you can see the trachea is fairly severely compressed, particularly in the lateral diameter. So in this particular case, things that stand out to me are the degree and the severity of compression, the degree of airway compromise, which obviously affects my decision-making in terms of anesthesia and approaching this particular case, and particularly consideration of doing this case with rigid bronchoscopy. The other thing that stands out is the absence of endobronchial disease. So all of, and obviously I'm not giving you a full video of bronchoscopy here, but all of the disease was extrinsic. There was no significant mucosal nodularity or infiltration in the trachea itself. And lastly, the proximity of this lesion to the vocal cords. It's a high lesion, but it did not extend all the way up into the immediate subglottic space. So those are all considerations for this particular patient. So again, any thoughts from the audience on choice of stent in this particular case, in Aero stent, silicone, covered Ultraflex, or an uncovered Ultraflex? All right, I'm getting a variety of answers. I see several of you have chosen Y stents, and in your defense, I did not give you comprehensive imaging, obviously, all the way down the trachea. So just to let you know, the mass did not extend that far down the trachea, so it only went down probably 3 or 4 centimeters. So that might change your thinking somewhat about the Y stent. I've seen a few votes for also covered Ultraflex and uncovered Ultraflexes, and I just want to point out that for some of these cases, the first case and the second case, many of you selected silicone stents, which certainly would be appropriate for some of these patients as well. Obviously, our focus tonight is on metallic airway stenting, but I just want to make it clear that certainly in some of these cases that's an appropriate choice as well. So back to the case. In this particular case, we chose an uncovered Ultraflex stent. So this is actually, this picture's really upside down. This is the bevel of the rigid bronchoscope. This is posterior. This is anterior. Here's the cricoid cartilage here. And here you can see the proximal edge of an uncovered Ultraflex stent. This is a slice here after the stent was placed with the stent visible in the previous comparative picture. So this patient had obviously a substantial improvement in their dyspnea and was seen over the next 2 or 3 months before they subsequently passed away 3 to 4 months after stent placement. So this stent was placed with rigid bronchoscopy under direct visualization. And again, there was no significant endobronchial disease or mucosal disease. So the decision to use an uncovered stent was in part based on that, and also in part based on the fact that this was a tracheal lesion, and just through anecdotal experience, we've often seen patients with uncovered metallic stents in the setting of malignancy handle mucus better, less mucus occlusion than longer silicone tracheal stents, perhaps because of some still residual capability of normal mucociliary clearance because of exposed or partially exposed mucosa. But I did choose this case just because we really don't put in our practice, and I think a lot of you would say the same thing, a lot of uncovered metallic stents in this day and age for malignancy. And I think a lot of times in the case like this, some practitioners would still, if they did choose an Ultraflex stent, would still choose a covered Ultraflex stent, although one could argue that that's not entirely necessary. Just a word again on the Ultraflex stent specifically. It's nitinol, as is the Aero stent, except it's woven wires. It has overall fairly good radial strength, and as I mentioned previously, was the most commonly used stent in the United States. It's covered or uncovered, and those also come in distal or proximal release, and it is self-expanding as well. And for those of you that don't know the history on Ultraflex stent, as I mentioned, this used to be the most common self-expanding metallic airway stent in the U.S. until about 2011, when it was off the market for about 3 years. So during that time period, the Aero stent obviously saw much higher use. And then in 2014, really at the end of 2014, the Ultraflex came back on the market with a slightly different covering. It's a permalume covering instead of a silicone covering, but basically it's been back on the market exactly 2 years. So as I always joke, I have three generations worth of interventional pulmonary fellows, or I should say 3 years worth of fellows who missed the opportunity to gain experience in Ultraflex stenting. So if you train from 2011 to 2014, you have to pick up this particular stent experience on your own. So let me speak just a little bit about stent selection in terms of length and diameter. I think for some of you, this is fairly straightforward and fairly routine, but in choosing the length of the stents, regardless of the stent type you're going to use, typically you'll use your CT scan imaging and probably more importantly, direct bronchoscopic measurements. And people have different techniques in how to measure. Oftentimes they'll use a rigid telescope or your flexible scope and place it distally in the airway past the point of where you'd like the stent to cover, and pull it back relative to some other fixed object, measure it with a tape measure or something along those lines. Obviously, if there's mucosal tumor, you'd like to overlap those lesions by at least 1 centimeter or more on each end. Now, typically our shortest metal stents were around 20 millimeters. Now we have some options that can't even go shorter than that, which again we'll talk about. Obviously, in choosing the stent length, we'd like to avoid jailing viable bronchi. And I can't emphasize enough how important it is, and I quiz our fellows on this often. You really need to know your airway lengths, at least what the ranges are as you make these selections. In terms of airway diameter, similar ideas. You can use your CT scan measurements. You can use a dilating balloon, such as a CRE balloon, to inflate to a predetermined diameter and see how snug the balloon is against the airway wall. I think this technique works pretty well. There is a commercially available stent sizing device that can be used to measure airway diameter as well, or what's the diameter of the airway relative to the rigid or flexible scope that you have. If it's a self-expandable metal stent, typically we sort of target a stent diameter that's going to be a couple millimeters larger than what the post-stent airway would be. And again, you have to know your normal ranges for your main airways, the BI, the main stems, and the trachea. Stents can be placed both with flexible and rigid techniques. From a flexible standpoint, I learned to do a lot of metallic stents under moderate sedation. We used to do this most commonly by placing a guide wire and then placing the scope next to the guide wire and advancing the stent next to the scope into position under direct visualization. Obviously, you do this through the mouth as an act of kindness to the patient and not attempt to place a stent through the nose. It used to be fairly common practice that stents could also be placed with fluoroscopy over guide wires, although this is fairly rarely done today. And of course, rigid bronchoscopy, which affords you a lot of control and direct visualization with a rigid telescope or flexible scope through the rigid scope. I'm going to skip the video for now. Just a couple studies here I'd like to highlight. This was one of the larger case series of metallic stents and malignant airway disease, 172 stents and 140 patients, and this is an older series. And these patients had mostly endoluminal disease, but some of them had pure extrinsic disease. And 23 out of 140 patients had complications, with the most common ones being tumor ingrowth, granulation, fairly low migration rate, as we typically see with metallic stents, and a median survival of only 3 months, which also is fairly common, as you know, in this patient population. This is a little bit newer paper looking at long-term follow-up in Ultraflex, specifically for malignant airway stenosis, 60 patients, mostly covered stents, and again, fairly routine complication findings with mucus plugging, tumor ingrowth, granulation tissue, and again, fairly low migration rate with a median survival of about 3 months. I'm just going to go quickly through a couple of these other papers regarding the Aero stent. And the original Aero stent paper from 2008 that led to the FDA approval was the largest paper still to date, with about 56 patients. These were all malignant airway obstructions. They had significant improvement in luminal patency and dyspnea, but there was a high migration rate of around 30%. And this is often quoted when discussions are about Aero stents. I think this number is probably a lot better today, and that's just from clinical experience and learning how to size the Aero stent appropriately. But we don't really have a lot of published data showing anything different than this. This was just a small case series of three patients and lung transplant recipients. And the University of Florida group published a larger series of Aero stents in patients with airway complications after lung transplant, specifically stenosis, malacia, or actual dehiscence, 49 stents in 24 patients, a little bit higher granulation rate and higher migration rate than you might expect to see in non-malignant conditions. But I know this isn't a malignant study, but this is one of the only other papers really published with the Aero stent. So the 3 papers I've showed you are about the only 3 publications of significant case series of the Aero stent in the literature. So let me move on to a third case. This is a 73-year-old male smoker with a known right infrahilar squamous cell carcinoma. previous radiation chemotherapy 6 months prior, and he presented with moderate dyspnea and mild hemoptysis over the last 3 weeks. Chest X-ray and CT scans show some right middle lobe atelectasis with moderate adenopathy adjacent to the right middle lobe bronchus. Going to just go straight to bronchoscopic findings. On bronchoscopy, there was a necrotic tumor originating from the right middle lobe bronchus with fairly significant circumferential narrowing, and this was mechanically debulked as much as could be done, and despite that, there was still fairly severe right middle lobe bronchus narrowing despite debulking. And I realize this picture is fairly close up, but what we're illustrating here is pretty severe narrowing of the right middle lobe bronchus just down to a few millimeters. So my question for the audience is, what would you do next? Would you balloon dilate the middle lobe bronchus? Would you place a stent, possibly and balloon dilate in the middle lobe bronchus? Or no further bronchoscopic intervention and refer the patient for consideration of additional radiation and chemotherapy? All right, I'm seeing a real mixture of answers come through. It's always fascinating to me to see the diversity, and of course I wish we could have an open discussion about this. But I see a couple of people did pick B as a possibility of stent placement. So I selected this case very strategically to raise a particular discussion that seems to be becoming a little more common in stent discussions. And that's the question of stenting smaller airways, including individual small lobar or even segmental airways, as this question has been raised, I think, at an increasing amount over the last couple years. This is the atrium ICAST stent. This is a vascular stent that's been around for many, many years, but it's approved for tracheobronchial use because that pathway was an easier pathway for approval when these stents were made. They come in very small sizes, which are not suitable for the trachea or larger airways, but it's stainless steel covered in PTFE. And the Cleveland Clinic group presented their initial experience with this stent a couple years ago at CHEST, clinical success for lobar and segmental bronchi for lobar salvage and bronchial stenosis. So this was 25 patients, 69 stents. Now there was a mixture of benign and malignant patients here. There were 10 transplant, 10 cancer patients, and the right middle lobe was the most common site of stenting, about 40%. And this was just a preliminary data. Now, the interesting thing about this stent, these pictures here are from a patient that I put one of these stents in probably about 10 years ago or 11 years ago. And this was a patient who I knew was actually going to undergo a pneumonectomy, and they had other complex benign airway disease in the left main stem. But what I found interesting with the stent was on the day the patient came back in for the pneumonectomy, this is what, and pardon, it's a very old picture, but this is what the stent looked like at the time of the pneumonectomy. So through coughing, the stent had compressed down to a narrow slit. And remember, this is a stainless steel balloon-deployed stent, so it doesn't have significant recoil. So when the patient had coughed and compressed the stent remained compressed. So there are definitely properties about this particular stent that would make me have some concern about long-term use in the airway. I want to just point out a couple other types of stents that are in a similar category as the ICAST stent. There's another stent made by Bard, which is called the Fluency Plus Tracheobronchial Stent. Again, really a vascular stent. And the Smart Control Stent by Cordis, which is also a nitinol stent. Again, predominantly a vascular stent, but there's at least one publication using this stent in lung transplant patients with anastomotic stenosis over a period of time in Israel, 36 patients. Significant symptomatic improvement, fairly high rate of granulation tissue, and no difference in survival. So again, smaller stents, a little bit more of a niche use in this particular population. But again, I just show you this to point out that there are several smaller stents that, while technically approved by the FDA for airway use, were original intentions of being vascular stents. And then just a quick word on metal Y stents in malignant disease. Now, these are not currently available in the United States, and there are several versions and products available in other parts of the world. And these were just two papers looking at small groups, 39 malignant and 4 benign patients in this particular group. They had a fairly high number of patients that were lost to follow-up and pretty high mortality. A third of the patients died within six weeks, and about a third of them had minor complications. And again, a second series with 38 patients for a malignant tumor with one case of fracture. About 25 or higher had 25% of granulation tissue, and several required bronchoscopy for secretions. But again, these are stents that are in development or already on the market in some other areas of the world. Just a few more comments. Obviously, immediate complications from metallic airway stent placement are fairly uncommon. Obviously, if you grossly undersize the stent, it can migrate immediately, or malposition placement, which usually can be corrected at the time. Bleeding, hypoxia, usually related to the procedure itself. And then, of course, more importantly, delayed complications, migration, infection, mucus plugging, perforation to the airway, and, of course, commonly granulation tissue, long-term stent fracture, strictures, halitosis you'll see in these patients. This is actually a stricture on the proximal end of an Aero stent. So there's a stent in the BI that actually that was placed for malignancy, but ironically caused a severe benign stenosis. And here's an old Ultraflex with dense fibrosis and granulation tissue in the distal end with retained secretions. Which of the following is true regarding airway stents and malignant airway disease? Aero stent has the lowest association with infection. Respiratory infection is a major risk factor for granulation tissue. Half of stent patients are infected in the first month, or the Demon type silicone stent has the lowest migration rate. All right, I see a lot of Bs coming in. You guys are fairly unanimous on this. And I just want to highlight this paper from the MD Anderson group, David Ost and colleagues. And this is a really great paper. It's really one of the largest stent series combining these three types of stents that we're discussing. It's a retrospective cohort in malignant patients, but it's a very large group, almost 200 stents and 172 patients. So it's a significant contribution to the literature. And just to highlight the key findings, and sorry, one of you guys just reminded me there that the data was prospectively collected, although I did say it was a retrospective cohort, so just to clarify that as well. Thank you. But the Aero stent was associated with increased infection. The Demon stent was associated with the highest risk of increased migration, and the silicone stent and lower respiratory infection had the highest associations with increased risk granulation tissue. And then subsequent study also in chest 2.5 years ago, stents are associated with increased risk of respiratory infections in patients undergoing airway interventions for malignant airway disease. Again, this was a group of patients undergoing therapeutic bronchoscopy for malignant disease. 24 of the 72 patients received stents. 16% of the stent patients would get an infection by 30 days. So a significant number, but not as high as the choice I had listed in the multiple choice question. So it seemed that the stent itself is associated with a higher risk of infection independent of some of the other findings that we often see in this oftentimes immunocompromised group of patients. And then just quickly, one other study to point out, additional data from the acquired database for therapeutic bronchoscopy procedures. Although there was a very wide variation in stent use amongst centers, just looking specifically at risk for 30-day mortality, stent placement was one of the criteria one of the findings that was teased out as increased risk for 30-day mortality. And that may just be because patients with airway stents are selected out as sicker patients as well, but just wanted to highlight that finding as well in this acquired data. So there are a lot of metallic and hybrid stents out there. Again, in this country, currently we're pretty much using Ultraflex and Aero stents. I did mention some of the other stents that are other predominantly vascular use stents that have some limited airway experience, and then there's other stents, metal stents that are used around the globe as well. I don't have time really to get into drug-eluting stents except to say obviously there's been a number of human and animal studies that are still underway looking at a variety of agents including mitomycin, paclitaxel, doxycycline, and others that are still in development. And of course, similar discussions, biodegradable stents for various means, typically not in malignant disease as well. So in summary, I think metal and hybrid stents are very effective at relieving symptoms. Again, I can't emphasize enough, they are foreign bodies, so I think they should be placed with caution. Complications are not uncommon, and in the future we hope to see other options as I alluded to. And my favorite stent-related quote came from Dr. Louis Freitag that I heard a few years ago, which was stent infatuation. And I think it's so important for us as practitioners who place stents. Again, the old saying, just because we can doesn't mean we should, and I think we should weigh very carefully the options and considerations before we place an airway stent. So thank you very much for your time.
Thank you very much, Dr. Shepard. At this point in time, we would like to reserve the last few minutes to open it up for the audience to participate and ask questions for Dr. Shepard. The easiest way is if you input them in the chat box for those of you who have logged in online, and we can read out your question and ask Dr. Shepard to respond. So any initial questions for Dr. Shepard?
That was an excellent talk. Do you find any differences in as far as ease of removal between the Ultraflex and the Aero stent?
Yeah, I think so. And the caveat is, you know, most of the time in placing these stents for malignant airway disease, obviously most of the time we're not removing them because the patients typically have limited life expectancy and die with the stent in place. the Aero stents, obviously, because they're fully covered, are less likely to granulate and attach, and oftentimes can be easier to remove in these settings. Even covered Ultraflexes, as you know, have uncovered ends, so there's still opportunities for them to granulate or for tumor to attach them to the airway as well. So, you know, it's hard to say definitively that the Aero is easier to remove because, again, in the setting of malignancy, it's done fairly uncommonly, but there are some features that would make it easier at times.
And we have some questions from the audience typed in. So first from Mel Imad. He says, thanks, Wes, for this presentation. When placing Ultraflex by rigid, do you prefer distal release or proximal release, and why?
Great. Hi, thanks, Mel. So we typically place all of our stents by a rigid, Ultraflex, Aero, and obviously silicone stent. So our Ultraflex stents are typically distal release, and what we often do is place, we do these all under direct visualization, so particularly if it's a distal airway, such as the distal left vein or the distal BI, a lot of times I'll place a small flexible scope down next to the stent to the point of deployment so that I can directly visualize where the initial deployment is taking place. And that just makes it easy for me to accurately see that I'm beginning the stent in the right location. Now, having said that, one of the things I didn't mention tonight is, you know, a general rule of thumb, obviously, when we're deploying any type of stent, is often err on the side of deploying it to distal because, as you know, it's always easier to pull the stent a little more proximal than to push it deeper into the airway. So typically, we'll use distal release with direct visualization, if possible, with a small flexible scope next to it.
Great. And we have another question that asks, how many open segments post-obstruction is worth to place main stem stents?
That's a great question, and I think what's behind that question is it often becomes a judgment call at the time of therapeutic airway procedure. If you're putting in a main stem stent, I certainly have had cases where I thought I was going to be able to open up, you know, the whole lower lobe or multiple segments, and on further investigation and debulking, I find that I may be left with, you know, a couple of basilar segments or 2 or 3 basilar segments. And in those cases, I think sometimes I will err on the side of going ahead and placing a stent that may even begin, you know, in the distal lower lobe, possibly only leading to 2 or 3 basilar, you know, segments, and then extending up more proximally, covering the disease. So I don't think there's a right answer. I think it may depend on other clinical features of your patient, or how sick are they? Are you doing the procedure because they have respiratory failure and they're on a ventilator? But you know, it's a tough question to give a definitive answer for, except, you know, we'd like to see at least more than 1 or 2 segments or subsegments.
And we have another question from Dr. Klaus Lesnow asking, how do you remove metallic stents if that's required? So, and again, in the context of malignancy, so all of our metallic stents would be removed with rigid bronchoscopy. And typically, metallic stents placed for rigid bronchoscopy are easier to remove because they've usually been in shorter periods of time than metallic stents that were placed for benign disease. So it's rigid bronchoscope, and without going into too much of the technical detail, sort of a standard technique of using the bevel of the rigid bronchoscope to begin to pry the proximal edge and free up the proximal edge of the stent from the airway wall, using forceps to
gently probe the stent out the lumen and try to separate it from the wall. There's obviously a lot of other technical techniques that we're not going to be able to get into in the conversation.
Great. And we have another question from Dr. Joshua Filner that asks, if you have a fracture of a metallic stent, under what circumstances do you remove it versus do you leave it in place?
I think that's a very uncommon scenario, particularly, again, in malignancies. When we've seen fractures, it's often in patients who've had stents, metallic stents in for very long periods of time, which, again, used to be more in the benign population. Obviously, we're not seeing many benign patients who still have metal stents left in this day and age. So I think it would depend on how much the integrity of the stent is compromised. If a stent fracture leads to compromised lumen, again, then it would be reasonable to take it out if the stent's not too embedded and it's not going to put the patient at significant risk. But if the fracture is not cause significant compromise in the integrity and function of the stent, it's probably not unreasonable to leave it in place.
Great. And we have an additional question from Dr. Rahul Sood, and he asks, do you perform routine flexible bronchoscopy 4 to 6 weeks post-stent insertion for treating granulation tissue and secretions? And if I may take the liberty of expounding on that further in asking, what is your routine post-stent placement evaluation and monitoring process?
Yeah, I think that's a great question. So specifically for our topic tonight, in the setting of malignant disease, we do not perform routine bronchoscopy several weeks post-stent insertion in the absence of significant symptoms. So we follow these patients very closely. We feel very strongly that we should never, ever place a stent and lose that patient to follow-up. So we do our best to get these patients back in clinic in the first few weeks. And as long as they're doing fairly well and they don't have significant symptoms that would suggest, symptoms or imaging that would suggest some type of stent complication, we don't do any routine bronchoscopy. Now, if you ask me the same question for benign tracheal stenosis and a silicone stent, I would give you a different answer, but that's not our topic tonight. And
if there's any other last questions from the audience, otherwise I'm going to ask Dr. Shepard one last question, which would be for patients who have metallic stents placed for malignant disease, do you routinely give them, what sort of pulmonary toilet mechanisms or methodologies do you use to assist them, or do you find that the covered metal stents, that they don't require any additional inhaled mucolytics or hypertonic saline, that sort of thing?
Yeah, another great question, sort of a stent maintenance question. So for really all of our stent patients, whether it's metallic stents and malignancy, silicone stents and benign disease, Y stents, we pretty much put all of our patients on some type of nebulized therapy, and that may be, if they're already on bronchodilators, it might be an albuterol nebulizer twice a day. If they're not requiring any bronchodilators, we'll do nebulized saline, and we usually ask them to do it at a minimum twice a day. And that's pretty standard for all of our stent patients, and we don't really alter that a whole lot between benign disease, malignant disease. And of course, as all of you know, there's very little to virtually no evidence in the literature to support this practice, and all of you probably would give a slightly different answer in what your stent maintenance routine is. But that's pretty much it. We don't use in most cases, any type of pulmonary muco-clearance device, such as, the vest or an a cappella valve or anything like that in most cases, unless the patient just really had, some other complicating factors or really profound mucus.
Great. And if there's no additional questions from the audience at this point in time, I would like to conclude our webinar, and I would like to extend my my profound thanks to Dr. Shepard for spending the time to put this together. This is a wonderful discussion, and we had a great time interacting with the audience. I would like to also inform the audience that our next webinar in the series will be in December. The date will be announced, and look for the email from the AABIP. The speaker will be Dr. Mike Machuzak, and the planned topic will be interventional pulmonology in dealing with complications from lung transplant. So with that, I will stop the recording and thank everyone for joining us tonight for today's webinar.